All right. Well, good morning, everyone, and welcome to today's webinar brought to you by Sun Life Financial, all about diabetes. My name is Paul Joliet, and I'm the Assistant Vice President of Philanthropy and Sponsorships at Sun Life Financial. And it is my great pleasure to welcome you today to what is our first ever webinar about diabetes, and that's here on November the 14th, which is World Diabetes Day. Now, diabetes is growing at epidemic proportions here in Canada and around the world, really at quite alarming rates. So much so that the World Health Organization has actually called diabetes the epidemic of the 21st century. So here in Canada right now, 1 in 3 Canadians is actually living with either diabetes or pre-diabetes. And in the US, over 30 million people right now are already living with type 2. That's almost 10% of the American population. And across Asia, the rates of diabetes are growing at epidemic proportions, and really the statistics are quite alarming. Now, we at Sun Life back in 2012 decided that we would make diabetes our signature philanthropic health and wellness focus. And to date, we've now committed more than $22 million to the fight against diabetes here in Canada and around the world. And we couldn't be more proud of those dollars we've committed. What we're also really proud of is our partners, and that's we here in Canada and around the world. We've got some great organizations that we work with to help fight this disease. And whether we're talking about how do we create awareness about the disease, how we prevent it, how we care for those who already have diabetes, whether we're talking about how to prevent complications, we have many different partners. And one of those partners we're going to introduce you today is the Toronto Rehab Hospital and the Toronto Rehab Foundation. And last year, we announced a $1 million donation to the Toronto Rehab Foundation to create what is now called the Sun Life Financial Diabetes College. And it's a tremendous online resource. And what it is, you can go on there, and there's 5 interactive modules, and they can teach you all about how to prevent type 2 diabetes and how to care for yourself if you already have type 2 diabetes. So it's all about how to live a healthier, active lifestyle, how to prevent complications. It also talks about how to adhere to your medications should you already have type 2. It's a tremendous resource, and I really encourage you to check it out. Now, before we introduce you to some of the doctors who are going to take us through today's webinar, I'd like to introduce you to Cindy Yell. And Cindy is the President and CEO of the Toronto Rehab Foundation. Cindy, over to you.
People didn't see it, but I just shook Paul's hand as we were passing each other as I was coming to the computer, beaming to you. Actually, I should tell people where we are right now. We are sitting in Toronto General Hospital. It's one of the partner organizations of Toronto Rehab, part of the University Health Network. And in fact, we're sitting in a room in Discovery District, which is University Avenue. So many of you may have heard of Mars Discovery District, but it's really the highlight, research center, one of the powerhouses, not just in Canada, but across North America, and in fact, around the world. You know, Paul, I think back to when we started our discussions about Sun Life's commitment to the diabetes platform. We started thinking about not so much treating people once they have it, but also preventing it from happening in the first place. And in fact, Toronto Rehab is really hot on this whole concept of prevention. Our goal is to keep people out of hospital, keep them not in a rehab setting, because rehabilitation, for those of you who have experienced it or have had family members that have gone through, is really hard work, and it takes one to be really driven and determined and focused to get through and back to living their lives. So prevention is about keeping people with their families, keeping people in their homes, keeping them working, keeping them living their lives to the fullest. I did want to also acknowledge not just Paul and his team at Sun Life, but specifically Dean Connor. And all of you know that Dean was named CEO of the Year by the Financial Post just this past week. What you may not know is that Dean was also campaign chair for Toronto Rehab Foundation, morning, Where Incredible Happens campaign. It was the largest campaign ever in Canadian history dedicated to rehabilitation. So I just wanted to thank Dean and all of you. So I'm going to stop right now and just say thank you again to everyone at Sun Life for your commitment to the community, for your commitment to Toronto Rehab, to helping us keep people well and out of hospital. And I'm going to pass back to Paul. Thank you again. We're shaking hands.
That's great. Thanks very much, Cindy. And yeah, as Cindy said, we are proud of Dean and proud of his association here with Toronto Rehab. And as I said before, extremely proud of our association with this great institution. It is certainly world-renowned. I'd now like to introduce to you Dr. Michael Sarin, and he's going to be our first speaker today. And I'm going to read these notes, but Michael is a bit of a rock star when it comes to diabetes. So let me tell you a little bit more about him. So Dr. Michael Sarin is a fellow at the Royal College of Physicians of Canada and a member of the Royal College of Physicians of the UK. He holds a Master's of Education degree from the University of Toronto and is a certified diabetes educator with Diabetes Canada. He's an associate professor in the Department of Medicine, University of Toronto, and is currently program physician and diabetes educator for cardiac and diabetes programs at the Toronto Rehab Institute. Dr. Sarin has been actively involved in Diabetes Canada for many years. He's made presentations to diabetes educators and has been a guest speaker at various diabetes expos in the Greater Toronto Area. Dr. Sarin's main area of interest is the development of patient-centered education promoting self-care. He is a recipient of the 2009 and 2014 Health Professional of the Year Award by the Canadian Diabetes Association, now called Diabetes Canada. Please help me in welcoming Dr. Sarin.
Thank you. Thank you very much, Paul. Toronto, where incredible happens. In 1921, there was a young boy, Leonard Thompson, who suffered from type 1 diabetes, and there he is in the arms of his mother at the age of 12. Down the street, discovery was made by Dr. Benting and Best of insulin from a dog pancreas. He was given insulin injection, and that's him a few months later. In fact, 6 months later. That was the miracle of 20th century. That's Leonard. Unfortunately, he died at the age of 27 with pneumonia because there was no antibiotic treatment given to him at that time. Number of incredible things have happened at University Health Network. In 2006, United Nations designated November 14th, the birthday of Sir Frederick Benting, as the World Diabetes Day, and we have been celebrating it since. I want to talk about now the global burden of diabetes. 230 associations worldwide in 170 countries feed the information to International Diabetes Federation. And here are some statistics. Worldwide, in 2015, there were 415 adults living with diabetes or prediabetes, and globally, 46% of adults with diabetes are unaware. In Africa, for example, in the African continent, 2/3 of people, when they're diagnosed with diabetes, are unaware that they have diabetes. There was a study done in Europe. People at the time of the heart attack are diagnosed, 1/3 of people were diagnosed to have diabetes at the time of their heart attack. It's a costly disease. Costs 12% of the budget in US dollars, $673 billion to look after people with diabetes. The focus of International Diabetes Federation this year is on women and diabetes. 1 in 7 births are affected by gestational diabetes. Worldwide, at present time in 2015, were 542,000 children with type 1 diabetes, and that population is growing by 3% per year. It's predicted that by 2040, 1 in 10, or 642 million people, will have diabetes. So we need to act now. The world's most populated countries, China, India, after that is the country of diabetes, with 415 million people, which is 100 million people more than the US population. What's the situation in Canada? According to Diabetes Canada, every 3 minutes, another Canadian is diagnosed with diabetes. 29% of Canadians are currently living with diabetes or prediabetes, and at least 1 in 10 deaths in Canada was attributable to diabetes 7 or 8 years ago. Today, 3.4 million Canadians are estimated to be living with diabetes. By 2025, that number is going to rise to 5 million. Again, costly disease, costing the Canadian government $14 billion per year, predicted in 10 years to rise to $7.5 billion. Why is it important to know if you have prediabetes? We get many patients tell us that I was told a number of years ago, I have touch of sugar, I have borderline diabetes. No action is taken either by the patient or by the physician. Usually a glib statement is made to the patient, cut out the sugar and exercise. What's meant by exercise, what cutting sugar means, that's not spelled out. Patients don't usually take any action because they feel well. In prediabetes, patients have no symptoms. For a number of years, it's like an iceberg concept. Diabetes on the tip of the iceberg, underneath, there's a mammoth amount of collection, which is really the danger zone. That's what's evolving. So the focus of International Diabetes Federation and Diabetes Canada is get at the people before they develop diabetes. Nip the evil in the bud. So prediabetes is really diabetes in training. The metabolism is being trained. Person is eating high carbohydrate content food. Pancreas is putting out insulin to cope with it till the system is saturated with insulin and it's no longer effective. That's what we call the cells become insensitive to insulin, or insulin resistance develops. People with prediabetes are as much at risk, in fact, double the risk of having a heart attack or stroke as compared to people without diabetes. By the time they develop diabetes, the complication rates are 4 times more, either with heart attack, stroke, kidney failure, amputation. So without intervention at the stage of prediabetes, 15 to 30% of people will go on to develop diabetes within 5 years. Numbers vary in different continents. Remember, these are 7 continents which are in the domain of International Diabetes Federation. So because it has no symptoms, patients don't go to the doctor. It goes totally unaware. So, but it's a reversible. This is the stage where diabetes is reversible. You hear lots of people advertising, we can get rid of diabetes. It's at this stage you can reverse it. Sun Life has created a website which is Sun Life Against Diabetes, an ideal site for people to become aware. You can download that site on your cell phone. It's very interactive. It will tell you what is the person's risk of developing prediabetes. 3 levels of risk come up: low risk, medium risk, or high risk. The CAN risk score is only designed for ages 40 to 75. Low risk for people over the age of 40, we suggest you get checked with a blood test. I will describe the blood test, which is called A1C, every 3 years. If you are at medium risk with a score of 21 to 32, get checked every year and institute lifestyle changes, which Paul will be getting into. And if you're at high risk, in addition to making life changes yourself, get the experts, see a nutritionist, see a dietitian, get into an exercise program. We have an excellent diabetes prevention program at Toronto Rehab with amazing results. I will tell you a little story there. And follow up frequently with the healthcare practitioners. When you see your healthcare practitioner, take the lead. Do start your self-management right there. Tell the physician that I did my own CAN risk questionnaire. I am at high risk. I want a non-fasting blood test, not fasting blood sugar. We don't do that anymore because that just tells you what you ate the night before. We want to get a wide spectrum of what's happening. I want a non-fasting hemoglobin A1C check, and the further frequency of testing will of course depend upon your baseline test and your risk level. So act now to prevent diabetes. Just a quick primer on what's hemoglobin A1C. By the way, it used to be called hemoglobin A1C. We dropped the term hemoglobin because it was too confusing for people. We have hemoglobin C for thalassemia, hemoglobin S for sickle cell disease, different types of hemoglobin. So it was very confusing. And people associated hemoglobin with being anemic. So that low hemoglobin means you're anemic. So this is a hemoglobin A1, which has been put by the nature in our red blood cells, which sucks up the sugar, which attaches to the red blood cells. And you measure what is the concentration of hemoglobin, which is sucking up the sugar molecules. And there's lots of sugar around in the body, lots of sugar gets stuck to the red blood cell. That's what we measure. Here are the most important thing to know. Normal hemoglobin A1C, I'll call it A1C, because International Diabetes Federation has said drop the term hemoglobin. Make it just A1C. So normal is less than 5.5%. People with A1C of 5.5 to 5.9 are at risk. Prediabetes is 6 to 6.4%. The person is going to spend 7 to 10 years in this stage. The horse is still in the barn. Once it gets out, it's going to run amok. It's going to be difficult to train it. So this is the stage where to take action. Once the A1C reaches 6.5, label is written here. I am living with prediabetes for the last 14 years. I am in this stage. My A1C is 6.1% for 14 years. How am I doing that? Diet and exercise. No big magic. What you put into it, that's what's going to raise the blood sugar. Beware. If you are taken something, the other day I said I must try my system. I took a scoop of ice cream and I said I want to make it not being absorbed into my system. I put some sunflower seeds on it and flaxseed powder. And did my blood sugar, it hardly arose. That's what the role of fiber is. Fiber doesn't let the blood sugar get absorbed, doesn't get rise. So fiber is critical. We shall talk about that at another time. So how to prevent prediabetes from becoming diabetes? Eat smart, move more. All that information is on www.diabetescollege.ca. It's downloadable on your cell phone. Please visit that site and you will get all the information there. Thank you very much for your attention.
Wonderful. Well, thank you, Dr. Sarin. That was really informative. And you know, what I was thinking about as you were talking there was the first statistic you referred to there, which was, you know, one in, you know, or every 3 minutes another person in Canada is diagnosed with diabetes. And as I'm sitting there, you know, thinking about you speaking, and all of a sudden going, there's another one, and there's another one, and there's another one, and it truly sort of puts that in perspective as to how alarming these growth rates really are. So thank you very much for that presentation. We're doing a stretch break. Perfect. Let's do that. Great.
We are going to do stretch break because as one is sitting down, particularly some of my people tell me I'm an accountant or a family doctor, sitting down a lot. What's happening? Your metabolism is slowing down. So we are going to show you without going on a cold day or a hot day to walk, you don't have to leave your office. People say, I can't exercise, it's too cold, too hot outside. Paul and I are going to show you how to do that.
All right.
Here we go.
Let's zoom in on you first, Mike.
Yeah, okay. So, American Heart Association has put up a website, Leslie Sansoni, S-A-N-S-O-N-E, Leslie Sansoni, Leslie you put on your laptop that video, and she is walking, doing exercise. This is what we are doing. The muscles in the leg are sucking up, particularly people with prediabetes. Each time we move a muscle, it's sucking up sugar from the blood because muscles only use sugar. So that's what's happening right now. Our metabolism is being activated, and Leslie tells you you can increase your intensity moving sideways, moving your arms up. All kinds of things are added to that stretch. Reminds me of my army days. That's all what it needs.
Good job, Mike.
Thank you very much.
Well, that's enough to get your heart going. Thank you, Dr. Sarin. I appreciate that. I now want to take this opportunity to introduce to you our next speaker, and he's standing over my shoulder right now. It's Dr. Paul O. And Dr. Paul O is the Medical Director of the Cardiovascular Prevention and Rehabilitation Program at the Toronto Rehabilitation Institute, UHN, and Assistant Professor of Medicine at University of Toronto. You must have a long a title after your name on your business cards. I was going to say it's got to be. He is the past president of the Canadian Association of Cardiovascular Prevention and Rehabilitation, and serves on the board of directors for the Core Health and the Cardiac Rehab Network of Ontario. And in September 2014, he was appointed as the inaugural Good Life Fitness Chair in Cardiovascular Rehabilitation and Prevention at the University Health Network and University of Toronto. And we've had the pleasure of working with Dr. O on the Diabetes College over the past year or so. We've had him speak at a number of different functions, and he is truly dynamic, and it's my pleasure to introduce Dr. O to you today.
Great.
Oh, that's right.
We're practicing safe hygiene here in our room. So thank you, Paul, and welcome to everybody online. It's great that you were able to take a bit of time this morning on World Diabetes Day to share in these kinds of ideas with us. I must say that I'm thrilled to be part of Toronto Rehab, which is a strong member of the University Health Network, and we're particularly enamored of this wonderful relationship with Sun Life Financial. Together, we've enabled education, empowerment of thousands of Canadians, and indeed people all around the world. I'm just getting back from a 12-week trip, or 12-day, it seemed like 12 weeks, 12-day trip through India, talking about non-communicable diseases and the burden of diabetes and heart disease in many regions of the world. So we've got lots of work to do. And these sorts of joint programs where we can develop resources that can be shared widely is one of the wonderful strategies that we can make use of. So we're delighted to launch this webinar. Perhaps it'll be one of a series, Paul, and we could talk about that towards the end. But bear that in mind if you think that this was a useful endeavor, that perhaps there are some other topics that we could cover off through the course of a year with periodic sessions like this. So in the next 15 minutes or so, here are some of the ideas I'd love to share. The first, that as Michael Sarin kind of described to us, that living with diabetes is indeed rather complex. And it's more than simple pamphlets, it's more than simple discussion with a physician, but we need a more robust approach to successful behavior change. And this particular joint initiative called the Diabetes College is something that we'd like to share with you, if you haven't seen it yet, that really embraces this kind of concept, that patient education with a purpose that really challenges or changes self-management and promotes healthy behavior is really one of the things that we need to get to. Because living with diabetes is indeed very, very challenging. It's more than just a label. We heard kind of scary numbers about how a condition like this is on the rise. When we tell someone you've got diabetes, welcome. It's like opening up a Pandora's box in a way. And it's no wonder that people will get overwhelmed. How much exercise do I need to do? Do I need to start pricking my finger and checking my sugar? What does healthy diet really look like? Do I need to pay attention to blood pressure and other kinds of issues now? Should I go get my cholesterol checked? And then the lower right panel is, wow, here's the world of medications all of a sudden for many individuals. So we ask people to cope with a lot of complexity, and it's no wonder that there might be challenges for a lot of folks. Diabetes Canada has a regular process to update professional guidelines. And I put this up really to highlight how challenging that this might be, even on the medical side, let alone the physician side. And this is the sentinel page of how one manages diabetes. And if you look at the amount of real estate that's covered on this page, don't look at the detail, but you'll notice that about 90% of the real estate on this page is about which drug should I be taking. We would love to counter that and say, really, that's an important part, but maybe even a bigger part of that is what you do in your day-to-day life. Medicines are one part, but it's what you do in terms of your daily activity. And I rib my endocrine colleagues by saying, where is lifestyle on this slide anyways? And if you look at it, it's kind of this vertical thing that says lifestyle on the left-hand panel over here. In some ways, when this is actually printed in a book, that lifestyle page actually ends up in the margin. It is actually marginalized. And if you don't open up the book enough, you actually don't see it. And you just focus on medicines. So there's a problem a bit with this medical model. Medicines are important, absolutely. But if we think of a year in life of somebody living with diabetes, and is it all about what I might say as a powerful physician who's been to medical school, I've learned a lot of things, all I need to do is tell people, certainly that's what leads to change. Think of the amount of time that a patient will spend with me, or family doc, or others. And we're well-intentioned people. Look, I'm a good person. I see somebody 4 times a year, maybe for 15 minutes at a time. If I do the math on that one, 15 minutes, plus they might see a dietitian, plus they might see a podiatrist, they might see somebody else. So maybe if we're generous, we'll get 4 hours with healthcare professionals through the course of the year. But they're spending almost 9,000 hours by themselves. Who really needs to be the expert in this kind of equation? It's a different model for how we might approach the management of chronic disease. So the last decade has seen us move more towards this notion of self-management. And our role as healthcare practitioners is really to enable people by providing the right kinds of tools, guidance, to help people be as strong a manager as they can be. Self-management is defined by the American Association of Diabetes Educators and others as an individual's ability to manage symptoms, treatment, physical, psychosocial, lifestyle changes. It's a lot of stuff because they are living with the chronic condition. As Mike said, sometimes we have good intentions, but we end up focusing simply on this kind of story. But diabetes is a whole lot more than just sugar. It's one element, but it's a small element. And just changing sugar intake is not really going to change the trajectory of the disease. Sometimes we end up doing this as well, that boy, you better pay attention, you're going to lose your foot, you'll go blind, your kidneys will fall out. Those are important messages, but it rarely does that sort of thing actually lead to successful behavior change. So our goal will be that self-management and education around that is much more than creating fear of complications. Together with Sun Life and Toronto Rehab, that we've been working together on building this patient management education program that really enhances self-management. And we would think about it differently, as opposed to me pushing drugs to people, which are important, but rather if we engage together and help people build skills and build confidence so that they can better manage their own condition, we can see a whole bunch of really good things happen when one becomes a successful self-manager. They will have better communication, better interactions with healthcare professionals. That's what it's about. What is it they need out of that interaction? Health behaviors change, like cutting down on smoking and eating better and exercising more. Symptoms improve, like having less depression, which is very common in people living with diabetes, having poor energy, which is very common, and those medicines that I prescribed, unfortunately a lot of people don't take them because of the construct that we had. But if they are an important part of the story, then let's actually build some skills so people can actually be successful with that behavior too. So we've been building around this theme of patient education with purpose. And we have this umbrella theme that's called Health E University. And within that, we're very pleased and proud to have the asset that is called the Diabetes College. What's different about this versus all of the other websites that might be out there? That we're excited because this is a place where we brought information that is truly evidence-based. It's written by professionals from our program and elsewhere, but it's also written by and co-created with our patients who sit on our teams and do editing, so that the material is really, really relevant to the learner themselves. We do our best to remove barriers to access. You know, one thing that I learned to be successful with these sorts of programs is that I have to learn how to translate English into English. What do I mean by that? The kind of English that I speak, you can judge whether it's good English or bad English, but medical English is definitely not the way to communicate successfully with people. Translating things into plain language is critically important to convey the messages and for them not to be misconstrued. So we spent a lot of time on health literacy. So the diabetes self-management education, as Mike Sarin introduced to us, would have 5 pillars to it. So this is the way that we actually build a school when we've had these conversations with our professionals and with our patients. That it's very important to start with the blue, that we understand and treat the condition, diabetes in this case. We need to know about sugar. We need to know about those complications. We need to know about treatment. But then pair that with the important health behaviors, like getting active on a regular basis and eating healthy and managing together psychosocial health so that we feel well. All of these constructs together go to the middle, that ultimately taking control of one's health is the goal of the educational program. So we were successfully able to launch just a year ago this product called the Sun Life Financial Diabetes College, a wonderful asset that was developed between our program with the generous support of Sun Life. And you see here the landing website here. And we're also very pleased that this is available in all kinds of different formats. I've been learning about the web. You know very much about the web, how important it is to have materials that can translate, resize, whether you're on a desktop, a laptop, a tablet, or on a mobile, that it will do all of those things. Making materials more accessible. You know, Toronto is a wonderfully diverse city. The GTA is a great place to live and grow up. It's also can be interestingly challenging because the number of languages that are spoken in this city, we are very much committed to developing resources that can be shared as widely as possible. Of course, we'll have the French language, but looking into Asian and South Asian populations, I bolded the Portuguese because we like the Portuguese. We have clinical partners in Brazil, and so, of course, the Portuguese language is there. A couple of weeks ago, I was actually at the Portuguese National Diabetes Meeting in Lisbon, and they were very keen on working with us in developing language materials that can be used there. So these are examples of kind of leveraging the expertise of programs in Toronto with Sun Life support that we can actually take this to the world, which is our desire. I'm doing this as the evil kind of empire builder. But truly, we really want to share and build and go as widely as possible. When you go to the website, you can actually download the entire book, and that was a deliberate thing that we want to make it as widely available as possible. If you open up the table of contents, you'll see that those 5 different domains are reflected in terms of treating diabetes, getting active, eating healthy, feeling well, and taking control. And each of the sections of the web or the book are identified and laid out in identical manner. And we try to do this to create as much opportunity for the learner to engage in the way that they want. Some of our patients love the printed book. They use it for weight training, I guess, or they love to turn pages and highlight and dog ear and things like that, and that's great. But if you're a tablet reader, then it's available there as well, or if you like to click through web pages in a non-linear format and view video, you can do that as well. Over time, you'll see more assets that will be added to this web platform. But let me show you a little bit more. So treating diabetes, we'll talk about the medications, yes, and the complications, yes. But other things that one needs to do to manage diabetes well. we talked about getting active. And one of the things in the getting active section, you'll actually find resistance training videos. So in addition to the marching on the spot that Mike led us through, the kinds of band exercises or actual dumbbell exercises that we use in our program are actually all up on the web platform. So if you're interested in doing this, or you have a family member, or if you're a healthcare practitioner on the phone, if you're a nurse manager and you wanted to direct one of your clients to some reputable, safe, effective programming, then it's there. And these are really quite lovely in terms of resistance training videos. They are sanctioned by our program. The gentleman displayed in the middle, Mr. Darrell Dukes, is actually a physical activity educator, and he's a diabetes educator as well. So some good people that develop these sorts of materials. The Eat Healthy section is bright, it's colorful. It'll give some basic skills around how to eat well and read food labels, for instance, and tips on shopping. And there's a series of very well-produced recipes and nutrition videos that are available, and we'll continually update the library here on an ongoing basis over time. So please come back and look and see what's new on the web platform. Feeling well, looking at depression, anxiety, hostility, anger, having positive relationships, these are all very critical to living well with a condition. Sometimes these things should be unearthed. They may remain under the surface, but they may be the biggest issue that we need to work on. It's not sugar and medicines, but it's actually the mental health issues that may be the critically important thing. And then taking control. So things like, how do I set a smart goal in the short term and long term, and then how do I create an action plan to get there? These are the critical tools to live well with the condition. So knowing targets, setting goals, overcoming barriers, achieving success is where we would love everyone to get to. And we're also delighted to be able to lay over a research evaluation into all the things that we do. One of the important distinguishing characteristics of our platforms is that we evaluate everything very, very carefully. If we provide education, do people actually learn from that education? And more importantly, if they learn something, will they actually change a behavior? Will they eat better? Will they move more? And then importantly, will that actually change an outcome? Will that change a glucose level over the long term? Will it change the A1C? Will it change whether someone ends up in hospital in the future? These are the critical important questions that we want to address. So by going through all of this sort of construct, we think that this adds a great deal into the environment. The Sun Life Financial Diabetes College, in collaboration with our program and Sun Life, allows people to become the experts in living with their own condition. We need to respect that. We need to build that capability in our groups. And that's how we're going to change the needle on the millions and millions of people living with diabetes. So self-management in diabetes was the topic for today. There are many other things that we could be talking about. Think about it on what you would like for your next webinar. There you go, Paul. I'm just committing to it. We're going to do it. I'm just going to assume that we're going to do it because we've got this set up now. So self-management in diabetes is much more than just sugar, that we have evolving roles. For us as healthcare practitioners, we also need to think differently about how we engage with people, and patients need to become differently enabled to become their own best expert. We can help support. Resources like the Diabetes College is a great place to start. It's education with a purpose. We should look at these kinds of pillars of understanding conditions, exercising, nutrition, psychosocial, and behavioral control, and we can get people activated for sustained change. So thanks. I'm at the end of my part. Now we get to go into a bit of a question and answer period. The best way we're going to do this, how do I moderate this? Can someone give me an idea? Debbie is going to do that on the phone. Debbie, so you're going to identify people who have questions. Mike and I are available. Paul Joliet's available if you have a Sun Life kind of question, I guess. Cindy Yell is available if we have a foundation-related question. Why not? Sure. Let's ask questions. Okay, so this is the interactive part. If you aren't standing up at your computer and running around at this point, does anyone have a question? I know this is not a shy group by any means, but I recognize it can be daunting on the telephone. In this room, let's start here in this room. And Jennifer, do you have a question? So Jennifer, who works at the Toronto Rehab Foundation, asked the question, what's the recommended time that might actually impact on blood sugar and regulate things? And the answer is anytime. How's that? Like, that's a good place to start, right? So Mike says that's great. So that's a bit facetious, but it's actually true. That so we could start with the general guideline that applies to people living with diabetes, or in the general population. I think you're very familiar with this notion of let's get 30 minutes a day, 5 days a week equals 150 minutes per week. And that's a great number for the population to strive for. It's not, there's nothing really magical about that. The relationship between better sugar or better heart health, or whether you live or die, is actually a curvilinear relationship with the amount of time that one spends. So any amount of activity will get you benefit. And actually the biggest amount of benefit comes at the left-hand part of the curve. So if you've got a large population that don't move, just getting people to move a little bit is probably the biggest thing that we can do on a population basis. Once you're moving a little bit, if you can move more and get to 30 minutes a day, that's terrific. If you're actually looking to really smooth out blood sugars, though, then we might encourage people, and people in our program, Mike, is that right? 45, 60 minutes a day.
Yes.
And not only do we encourage the walking kinds of programs at a slightly vigorous pace where you're a little bit short of breath, a little bit sweaty, then we'll ask people to get in a couple of days of that weight training. All of that together really smooths out sugars. And the thing that we've written in papers and in kind of educational documents would be that this can be as powerful as any medication. The only side effects are you get a little sweaty, you get a little smelly, but it's good for everything else. So Jennifer, thanks for that question. So I hope that's okay. Every little bit counts, and we can work towards those goals. Where we are now, we'll do a little bit more. Anybody on the phone have a question yet?
We have a question from Waterford. Hi there. I was just wondering what your opinion is on doctors that will prescribe, say, glucophage or metformin, maybe to someone who's pre-diabetic as a way to kind of prevent full, type 2 diabetes kicking in.
Yeah, thank you for the question. So one of the very standard diabetes medication, the standard medication that's offered first to people living with type 2 diabetes is called metformin. One of its brand names is called glucophage. It's interesting. So it certainly can be helpful. But if you actually look at the literature on this, there was this very interesting study published about 15 years ago called the Diabetes Prevention Program. And in that study, they took a few thousand people living with prediabetes, just slightly elevated blood sugar, and they were randomized to 3 different arms. The first arm got the usual smart medical advice that doctors give. Your sugar is a little bit high. I think you should be careful. I think you should get more active. I'll see you in 5 years. You can guess what happened to that group. The rate of conversion to diabetes was about 10% per year in that group. The second group actually got that prescription called metformin. And it actually helped a little bit, that there was actually about a 30% reduction in the risk of developing diabetes over the next 5 years. So that went from about 10% down to 7% per year. The third group was the magical group, though. The third group is the group that instead of getting pills, was offered up very structured advice on how to get active on a regular basis, eat better, take control, set goals, do all of the things that we talked about. And in that group, there was at least a 50% reduction in risk of developing diabetes. So 10% down to 5%. So it's interesting, physicians aren't very good at that. So they're very good at giving prescriptions for metformin. But really what we should be doing is instead of prescribing a pill, we should prescribe a health coach to help people get active, eat better, manage relationships, take control, and that's going to be the most effective intervention of all. Does that answer your question, Waterford?
Yes, thank you.
Great. Thanks for the question.
All right, and we have a question coming from Wellesley. Could you speak about the role that body composition has in preventing or developing diabetes, i.e. visceral fat versus subcutaneous fat?
So I'm inviting Dr. Sarin to come sit with me. Do you want to pull over a chair, Mike? Yeah. Visceral fat versus other kinds of fat. Very important kind of issue.
Important concept to know, because visceral fat is an active fat, metabolically very active. It promotes insulin resistance. But don't look at the weight overall. That becomes the focus. People having liposuction for weight reduction or having all kinds of surgery for weight reduction. Weight is not the issue. Where the fat is the issue. So fitness versus fatness. Fitness wins all the time. So don't make losing weight as the focus, which is the popular concept out there. Number of people making billions of dollars across America by making people lose weight. In fact, if you got fitter, the muscles beat up on fat cells, and the muscles win all the time.
So if I may add to that, I agree completely. So that if we're looking for a marker of body composition that is more relevant to what happens to people in terms of diabetes risk or cardiovascular risk, therefore it's not the weight on the body scale, but rather it's the size of the belly perhaps. So waist circumference is a far better marker than weight on a scale, because the waist circumference can be a better reflection of how much fat is around the organs, or visceral fat as you've described. That's the nasty stuff.
So scales are for fish. That's what we tell people.
Are the language groups mentioned in the presentation ones more at risk of diabetes?
Yeah, the language ones, you're absolutely right. It's actually interesting. So if we think of Chinese population or Indian population, South Asian, that yes, they are more at risk for developing diabetes. It's actually interesting, Mike. So I took up your challenge and I did my CAN risk score yesterday. So I'm now 53, Cindy, and I run regularly. I did 3 half marathons this year. I eat well. I have lots of fruits and veggies. But because my parents and me, my genetics too, so I come from South Korea, that I end up with a score of 23 points on the CAN risk thing. So I end up in a medium risk category, which will never change, right? Is that right, Mike?
Yes.
I can't change any of that.
Genetics
Well, maybe
is like
I
a
could.
can of gasoline waiting to explode.
Thank you for that analogy, Mike. So this encourages me to continue to move as much as I can and be thoughtful, and it reminds us not to be complacent with this. Getting back to your question, yes. So part of our focus on those language areas are indeed ones who are at greater risk. They also reflect our patient population, of course, in Toronto, which is incredibly diverse, and we have large representation from those communities. Coincidentally, I think they also align well with Sun Life's presence in different parts of the world. So that's a nice kind of alignment as well. So for all of those reasons, we're focusing on those populations. Does that answer your question, or did you have a follow-up?
Yes, thank you.
Great.
And we have another question in the chat pod from Vanessa. Is cutting out carbs a good way to avoid type 2 diabetes?
Remember, 2 most important things. Brain only uses glucose. In fact, brain uses 5 grams of glucose every hour, whether you are asleep or awake or whatever. And then the muscles need glucose. Muscles only consume glucose for energy. So we get lots of people going through different programs on drastic reduction of carbohydrates, and they are told, cut out the carbohydrates completely. The result is they are walking zombies. They are walking on the cloud. They are feeling tired. The body is very clever. Where does it begin to get the energy from? From the protein. So their muscles get shrinking up. They can't exercise. And of course, they are cutting out now food, and the muscles are not exercising. They lose weight like 20 pounds in the first 3 weeks. By the way, that's pure water. That's not fat. And after that, the weight slows down. And the diet doctor tells them, you're not following the diet I told you. Look, you lost 20 pounds in the first 3 weeks, and now you're not losing weight. Put the guilt on the person. Not a good strategy.
So we're not fans of, I think you can tell, of any sort of restrictive kind of diet in any ways. Nor are we fans of focusing on any one particular food, nor are we fans of any particular supplement. We are big fans of patterns of eating that are healthy. And the best evidence for kind of better diabetes management and certainly heart disease prevention is the pattern of food that you eat. Eat more plants, have more vegetables and fruit, have more fiber that Mike talked about. Don't avoid fat. That's actually an interesting thing that's resurfaced in the literature, but have a healthy fat. Have an avocado, have some olive oil.
Mediterranean type of food.
So one of the best studies that we talk about is one, if you're looking for something, called the PREDI-MED, P-R-E-D-I, MED study, that looked at about 7,500 Spaniards over a period of 5 years, some of whom actually had pre-diabetes. And over that 5-year period of time, people that followed a more conventional pattern of eating versus one that emphasized more of the Mediterranean style, so fruits, veggies, fiber, fish, healthy fats, they had about a 30% reduction in risk of heart disease and death. So food is powerful, but make a sensible choice. There is no data about cutting out carbs and having a successful outcome in that way.
What is the percentage attributed to pre-diabetic to hereditary if you have a family member that is diabetic? So I believe the question is are you able to estimate how many folks who are pre-diabetic from a hereditary perspective?
Yeah, difficult to tell that number because it differs across the different continents. So they say genetics perhaps accounts for about 25% of risk, 75% of what we eat, whether we move or not, in general terms.
One other interesting thing is that if you actually go to the Sun Life Against Diabetes website and look at that CanRisk tool, it actually breaks down those questions in a very interesting way. So you could see the contributions of your family history, ethnic background, as well as kind of other risks. So for yourself or the clients that you might be working with or your family members, for you in the States, it makes great Thanksgiving table talk, doesn't it? Before we serve the turkey, let's do CanRisk scores. Maybe not, but it's an icebreaker, isn't it? Who's got the best score? But more importantly, what can you do about it? And some things we can't change, although we wish we could, like who's in your family. But other things maybe you can change, and that might be the exciting commitment and a point of gratitude during Thanksgiving.
So one shouldn't think that, oh, my parents had diabetes and I am doomed to develop diabetes. Take the necessary steps.
Great, thank you. We have another question from Waterloo King. Is type 2 diabetes a reversible or curable condition?
I give the example of patient, I just had a patient who says he went to Alcoholics Anonymous and he goes to the meetings and he says, he stands up and you have to say, he said, I'm an alcoholic. My last drink was on Christmas Eve 2010. Look at the words he's using. I'm an alcoholic. So the person with diabetes who is well controlled will say, I am living with diabetes, but my A1C is so and so. I am controlling my diabetes. So on similar note, God forbid, if that person had to fall and break his hip and hospitalized, there goes eating right and exercise, and his blood sugar will jump.
So thanks, Mike. So, if part of the question was, so diabetes doesn't go away. It's there. It's part of the package. It's just under the surface. It is possible to reverse medications, though, and indeed get off of medications for some people, and manage the condition with kind of attention to lifestyle alone. So maybe that's the other emphasizing point here. Okay. Anything else in the pod?
Yeah. Will the A Guide to Help You Live and Thrive with Diabetes be available in the Spanish language when the Latino community in Canada is growing fast and they are at high risk too?
Thanks for the question. We'll put it on the list. We love the translation work. We're keeping people very busy. But we'll put it on the list. Thank you. And of course, when we get to our Latin partners, we're doing this with our cardiac programs. We're working with programs in Mexico and Colombia and Argentina and Paraguay, etc. And we know that the prevalence of diabetes in certainly Mexico is huge, isn't it, Mike?
Yeah.
Okay, so a question in this room, the last question, is the relationship between heart disease and diabetes. Mike?
So that's called the metabolic syndrome, right starting in prediabetes before the blood sugar is even reaching high proportions, hasn't risen to that level. There is also development of hypertension, high cholesterol. That's happening because there is an unused hormone. Remember, the idle hormone is a devil's workshop. So insulin, which is being produced like crazy by the pancreas, has side effects. Insulin is a salt-retaining hormone. The blood pressure begins to rise. The changes in the metabolism, the cholesterol begins to rise. So we have not only the blood sugar rising, but the patient is developing high blood pressure, high cholesterol, physically inactive, genetic load. God forbid, as a person is a smoker. See the number of risk factors? That's why the risk of heart disease and stroke increases in prediabetes phase.
Yeah, so people living with diabetes are at about a threefold higher risk of developing heart disease. Similarly, as Mike mentioned, sometimes when we see people with heart disease, their first heart attack or the stress of heart surgery, that may be the point where actually diabetes is discovered. It was always there, but it's just that thing that tipped it over to, for recognition. In our cardiac program, probably 35 or 40% of people in the heart program are living with diabetes. So it's a very common overlapping condition, and unfortunately it is something that goes hand in hand, and we definitely need to be aware of that. So we're delighted that we have resources that can address both populations, so that's terrific. So we've used the hour. We're grateful to all of you who are able to take the time and join us for this webinar. We're grateful to Sun Life for this opportunity to join together to run the Diabetes College and to run this webinar. And we're quite serious that we would love to see this become a regular series of sort, frequency to be determined. Hopefully you'll find it of interest, but maybe there are times when we can talk about nutrition in detail, or exercise in detail, or medications in detail, or health tips in detail. So stay tuned. I know the team has ideas, and undoubtedly they'll bring that to you. So thank you all for joining us. Thanks to our AV team for helping kind of steer this webinar in the right way. And we hope that all of you have a great day. Thanks very much.